Hi everybody, it's Dr. Pierce again. It's week 10, so we're double digits. So nobody's kicked us off. I haven't insulted anybody. So we keep going. And what's exciting is that we're seeing a lot more people viewing it, visiting it, and actually making positive comments. So like I've said multiple times, we're doing this more. The way we came up with this is really a way to communicate with the patients and people that we know and don't know, and it's really been helpful for the most part. We're getting more questions, like I said last week. We're having to choose which ones to go with, and again, if we're not getting to your question, give us a call or email us and I'll try to answer it that way. But again, the best thing to do is always make an appointment if you are having an issue, but we're trying to get more general information out, and the questions are actually getting more detailed, both on a personal level for me, but also with personal levels for the patients too. So we're gonna get to, I know last time we talked about the Rock Doc stuff. Someone else is asking actually about how I got into doing this and talking about the issues with my back. So if we have time, we'll get into that also. But to get to the first question, is osteoarthritis in my knee. My doctor says the cartilage in my knee joint is gradually wearing away, and if I don't address it soon, I'll be dealing with the effects of waiting. It's not bone on bone, but when is it time to see a surgeon? So, this is a very common issue, and it's happening at all different ages. This really isn't a young issue, but it can be happening to people in their 30s, as early as their 30s. 20s, then it's a real big problem. But more commonly, it's when you hit 40 to that 60 range, you're starting to have knee issues. If you had an issue as a kid, then it accelerates. And to talk about that for a second, it's like a micro trauma. So if you have an injury early on, so if you're a younger viewer, if you have an injury to any part of your body, what happens is that you start getting what we get modeling. And that's where we throw out the term osteoarthritis or bone spurs. When the body gets injured, and we can talk about the knee because the knee is the most common. If you tweak your knee, if you're down for a couple days, if you said, I had a mild meniscal injury, all that stuff starts to cascade of the aging effect even quicker. Or I talked last week about alignments. If your body's out of alignment, you start wearing it out a little bit earlier. I use the example of the car where if one car tire is out of alignment or there's less air, it's still going to work for you, but you're going to pay for it later on. And you can see the tire wearing out, which is very common in the knee. The most common part of the knee is the inside part. So if I actually grab a knee, so if we grab the knee and we show you, this is actually the outside. This is where the kneecap would be, and we've taken that off. So outside, inside, and then these are the big ligaments inside called the ACL and PCL, the anterior cruciate ligament and posterior cruciate ligament. The meniscus here is what is like we call the cushion of the knee. What happens is it wears out a lot more commonly on the inside, on the medial aspect, so the internals part. And again, if you get back to my discussion of last week, you have vectors. So there's force vectors that are going through, which actually if you're out of alignment or your foot's flat, or I talked about my son, we're working about getting him on the outside of his foot, because if you're not, if your foot is collapsing in and you're losing your arches, you're going to wear out the inside of the knee, which is the most common thing. So if we can work on a prevention program, thinking that this person who's asking, we're kind of a little bit beyond that, but we still have a lot of things we can do to prevent the surgery down the road, the prevention down the road, the strength. What we talk about is the core musculature. The core musculature around the knee is very important. So there's a lot of things to do. So your physician is absolutely right that as you age, you're gradually wearing it out. I don't know if you're someone that had an injury earlier in life and you have an accelerated process that you need to be more proactive about, but either way, we need to have a preventative program or a proactive program to reduce the amount of what we call the aging process. So when is it that you want to talk to the surgeon? It's when it's so unbearable that you have to have either surgery, or if it's just a meniscal injury where I said where the cushions are, where they'll go in, they'll clean it up. So that's called arthroscopic surgery. So they'll go in there, and sometimes it's real easy. They just clean up everything. You have frayed edges. So if the meniscus, there's a fraying of the meniscus, which is the cushion part, or the other ligaments, you kind of, I consider it like dead ends in your hair. They start splitting, there's problems, it's not good nutrition, not good growth, not good circulation. You cut that dead end off and it's able to create a healthier piece of hair. Same thing with your ligaments and mostly the ligaments. So you can do that. But to go from a non-surgical, which was what we do and we focus in on, is that we're talking about, what can we do to prevent the slow down the aging process. A lot of times I talk about full flexibility. I want full range of motion. If you're being blocked or guarded, that's another issue. You do want to focus in on the strength of your leg, the core muscles. So the biggest thing that I've mentioned before is the hamstrings versus the quadriceps, so the muscles in front of your leg and behind your leg. And we're talking from your hip down to your knee, that these are very important to tune into. So it's a 3-to-2 ratio. So you want good strength in your quadriceps and your hamstrings to preserve your knee. When we really start getting down to it, then we talk about the muscles on the inside and outside, which changes your vector forces. And then there's tendons that can be involved. So it's more about an evaluation that needs to be done to prevent it. Because nobody's crazy about surgery at any level, especially if it's total knee replacements. What we're trying to do is prevent the total knee replacement or the scoping. What's exciting now is we've always had injections. We've always had the steroid injections to do to cut down the inflammation, cut down the irritation. The offset to that is that over years and multiple times you can cause a premature or a faster aging process to the bones and the ligaments, which we've been doing for years. There's another thing called the chicken whatever hyaline cartilage that we want to inject in there. That's what we call the series of 3 or series of 5. But the bigger thing that we're pushing now, the biggest thing we're pushing now is platelet-rich plasma and stem cell, which in the knee is the most common and most well-researched and showing the best benefit. So to answer your question, yes, there is many non-surgical options to do that. If you do need surgery, then we would actually get you with the surgeons that we're comfortable with. But there's a lot of steps between a little bit of a knee ache, a little bit of weakness, and especially if it's not bone on bone. So there's many options that you can do before the surgeon. To say when you need the surgeon is when it's unbearable all the time, it's swelling all the time, and you're just feeling unstable. So I'm getting the push to go ahead and keep moving along here. The next question, I've had spinal injections, epidurals before, but they were painful. Are the injections you perform painful? Do you take patients who have had injections done previously with someone else? So I'd like to say absolutely no, but that's not true. I mean, what we do is I actually see a lot more patients that are coming from other situations. And I'm not judging the other situations, but that's really what's the harder part. Because we're known to take care of the harder cases, a lot of the primary cares, maybe the patient gets to me after they've gone to someone else. And I'm sure some of my patients have gone elsewhere too, but for the most part, we take on a lot more issues. And what we do is we're spending a lot more time taking a step back so we do create a successful outcome. And the other thing is we create a successful anticipation of what's going on. I'm not the doctor who comes in and says, "Oh, I'm going to get you 100% better. We're going to do we're going to do 3 injections. You're going to be out running and doing all that." No, I'm realistic. I mean, we do a full evaluation, which is huge, especially with the spine. The spine is a full evaluation. It's not like evaluating an elbow or a knee. There's so many factors going into the back. There's so many rotations. It's not a 1, 2, 3 examination because you're taking everything to effect. Especially with us, we take that holistic approach. So I'm taking everything from the shoulders down at some point. Realistically, hopefully it's just from the hips down to the ground. But again, we need to take care of what's going on up above. And you'll get to like good therapists with myself that we are engaged with, is they will evaluate what's going on above and below the situation. So it's a team approach again, which I speak of a lot, that it's not just, we have our protocols have worked in our situations. But when everybody's on the same team, then we're looking at much better success rates. So yes, to simplify the question, yes, we do take on a lot of other patients that have injections with other people. But that's another thing. It's like, well, I had injections with somebody and now they're telling me I need surgery. That's not always true. It still leads to unnecessary surgeries. What I've talked about multiple times is there's different techniques of the injections. I feel like we've perfected our techniques for what's going on, both from a physiological standpoint, but also a physics standpoint. I mentioned it before, and for those who didn't hear, when you're doing an injection into an injured area, into the spine, so here's our little spine here. So this is the front, this is the back, these are the nerves. Well, if I'm having a problem with this nerve here, and I'm pushing fluid through the tailbone or in the mid part of the back, and I'm pushing 10 cc's of fluid into this area, what's going to happen is if this is the blocked area where the problem is, all that medication is going to flow away from the problem. Because we know by the laws of physics, medication or any fluids will flow away from the obstructed area. It'll flow to the place of ease. No different when we're doing an injection in your spine and we're just doing a general injection, which I oppose everyone not to do, to make sure that you're having a very specific injection to the area that's a primary problem. So a lot of times, even though you've had injections with someone else, that doesn't mean you need surgery. It may mean you need another evaluation of someone who's able to do it with a system approach. So if you are in a system approach and it's still failed, then that may be a chance for you to consider surgery, or if it's just so painful, what we call the surgical emergency signs, then you need surgery. But to answer the question again, are they painful? We try not to. We're very cautious with everything we do. I usually describe it as everyone who's had their blood drawn, you feel that little prick of the needle, and then we numb it up. And then you feel a little prick of the needle when you get your blood drawn, then you're fine. Same thing with the injection. The other thing I will say is that we're going into the area that's very sensitive. So I numb it up. I'm very generous in the way we numb things up, and we try to make everybody as comfortable as possible. We have anesthesia available for those who need it, and we put you into la-la land. So our goal is to not create more pain, but to take away your discomfort. So hopefully that answers your question in a lengthy way. The third questions, we'll get back to this one. Someone asked me how many herniated discs do I have. If I don't get back to it, I have 3 herniated discs that I've had since I was 15 years old. So I'm very sympathetic to individuals, but I'm also not sympathetic for those who make excuses on why they can't get better, because I do it on a daily basis. My kids make fun of me. I just had a discussion with my son, my daughter's boyfriend, that I feel I'm more active than all 3 of them put together, and they're like, you need to be. So we won't read into that answer, but moving on to the next question, and we'll come back to that. How long do you anticipate doing online appointments? So right now, I am basically keeping my mouth shut of predictions. When this started back in March, we felt it was going to be 3 to 4 weeks. And everything I feel like I'm doing, I'm like, yes, next month, we're going to be better. It feels like it's here to stay. We're actually starting to change the way we're dealing with the telemedicine because we are getting so busy. We're getting more of a streamlined process and getting the process done a little bit better. But again, we're not compromising any of the care. We are going to be doing telemedicine. I don't know when it's going to be ending. We know at least for the next 2 months we're going to be doing it. So we're available for telemedicine. I'm not sure how long. The other exciting news is we have a new doctor starting, Dr. Bonet. And we're excited about him coming in. He's excited. If you've gotten the emails, we're gonna try to get him on Facebook Live with me one of these days. But he's exciting. He's the younger guy, the younger version of me, hopefully. But with he's got that U of M training, so we'll see if he's even better. Right now, he's got a lot. He's learning. He's phenomenal. He's great with the patients. He has a lot more patients than I do, as far as personal, not patients as doctor patients, but actual patients for some of the issues. But the thing that's exciting with him, he's bringing me a lot more excitement because like I said before multiple times, we do a lot with cutting edge medicine, what's the latest and greatest. And the good news is that I'm not far off to what's currently being done. So that's an excitement. That's a selfish way of saying I feel like I've kept up, but he's got some new techniques, new way of doing things. So he's gonna be able to do things that I don't necessarily do. He's learning to what I'm doing. So it's going to be a mutual improvement and excitement. So we're a real good cohesive program from what we're seeing. And another thing I wanted to mention, he's going to be doing telemedicine starting here in the middle of August. So that's going to make more room for me to do a little bit more of the PRP and stem cell stuff we've been putting off. So for those who are thinking of it, we're definitely available for everything that we do, which we're expanding because he's got more abilities to do different types of injections, treating headaches. He likes dealing with Botox. So for those patients that I kind of didn't want to treat the headaches, that's kind of his specialty. So if you've been avoiding it, you can probably call, make an appointment with Dr. Bonette for that. The other big exciting thing, I don't think I've mentioned, that Michigan Sports and Spine has actually expanded. We've expanded our offices. Obviously, our Troy office is still on hold because of the governor, but our Livonia office is blossoming. But we also opened a new relationship with Dr. Abrahamson down in Wyandotte area. So she's a big part of an improvement of what we can offer to our patients. She just has, what's nice about us is we're all physical medicine rehabilitation, but we've all taken on another subspecialty where I'm focusing now on regenerative and stem cell and things like that. She's now going to be one of the top peptide treatment individuals definitely in Michigan and now in the country. She's going to complete some training here coming up next month. So it's above my head. I've told Dr. Bonette he can kind of help with that, and I just have a simple understanding that it's helping the body recover. It's all about quicker recoveries. We're talking about our IV therapy again. So what's exciting is the COVID's kind of put us on a delay, and all this has been set up as of January 1st, and now it's coming to, it's still going to come alive. COVID's not going to stop us from trying to improve. And our goal is to really, do things to be more preventative. So I've talked about it slowly about COVID and everything else, that we need to be healthier. Everything needs to be healthier. We need to watch what we're eating, a nutritional standpoint. We have a whole nutritional virtual team. We have trainers on virtual teams. So that's the thing that we're building and we're moving forward with. So we're building a larger team both within our practice and virtually outside our practice. So our full goal is to create a more holistic, non-surgical, non-narcotic, healthier lifestyle that we're trying to bring to you through Michigan Sports and Spine. And bringing these two in is really where we're trying to focus, and they're going to be just a total asset to the practice. So, tell your friends, review yourself, check us out, challenge us on what we're doing. You can research elsewhere. But as far as what we're doing, we feel we're going to be cutting edge even across the country once our program's fully together. So we're excited for that. So getting back to my question, how many herniated discs do you have? Unfortunately, I was playing basketball, high school basketball, and I got undercut. I didn't land on my feet. I landed on my tailbone. It put me to the point that I couldn't walk for 3 days. I saw one of the top surgeons in this area at the time, which I did have conversation with later in life, basically told me, you don't need surgery, you'll be fine in 2 weeks. I found out my first year of medical school when MRIs were first invented. This was on the East Coast at Rutgers, where I went to medical school. I volunteered for one of the first MRIs being done at our medical school and on the campus, and we found out that I had 3 herniated discs then. I had to go through medical school, which most of you know, we don't get to dictate how our life is. And then through residency, which again, we don't get to dictate how our life is. Another quick story, we put my MRI was put up in my internship year as a teaching film. And one of the top physicians was doing rounds, and I was in those rounds. He didn't realize it was me because my name was marked off to block it. And he asked everybody to guess how old this patient was. At the time, I was in my late 20s, and they guessed me at close to 60. So that's a reference that I've made, and actually it might have been the start of my passion of what I do here. So with all that being said, don't have sympathy for me, but I don't have sympathy for a lot of patients because there's a lot you have to do. And I know it's a lot of work. I do it on a personal level. I do it on a daily level, and sometimes I slack off. And for the last couple of weeks, I have slacked off for my home exercises. and it's actually put me in a little bit behind. So I'm back to my biking, I'm back to my kayaking. I encourage you to make sure you do your stretches, your flexibility. Our program is simple. Our program is we get you out of pain, we restore your full motion, and then we strengthen condition. So that's what you need to do on a daily basis. When we talk about this on a daily basis, I'm hoping it's helpful to you to understand what we need to do. In signing off here, I know we're trying to keep it in about 20 minutes, 20 to 23 minutes. We're at the 20-minute mark. So again, I'm encouraging you. I do appreciate everybody doing this. I do want to get out to as many people as we can. We are taking on new patients, especially with the new doctor. We may be a little bit behind. Be patient with us, but call us and give us your feedback. Again, big shout out to the new doctor starting within a month, Dr. Abrahamson, and to our virtual team, which we're continuing to compile. So that's where all the yoga's coming from, all the Pilates, all the stretches, and everything else that's good. So to summarize, basically stay active. We're trying to do this with our talks is end with talking points. So it's always 3 points I'll end with. You need to stay active. Like I said, I do it personally. It's proven. It's always shown to be better than being sedentary. For every day you're down, you need 3 to 4 days to catch back up. Who and what we're treating and what in the treatment you choose matters. So not every physician's creative, not every chiropractor's creative, not every therapist. You need to do your homework. For us, challenge us. You can challenge me. I'm very confident in what we do. I'm not afraid of you getting second opinions or other views. We're very confident with the education I have, and especially the 20 years of experience that I have, and the abilities of what I can and can't do. And that's the other thing, is make sure the physician's honest with you. I'm comfortable taking care of this. I've taken care of this. I know what's going on. You know what? You're a little bit outside my box. You need to be referred here. So make sure you evaluate and challenge whoever's treating you. Adopting the new normal. The telemedicine is definitely part of the new normal. There's a ton of positives coming out of it. There truly is. I'm getting to see people's, grandkids, situations they're living in, animals that they're dealing with, obstacles they have at their home, workouts that they have in their home, beautiful pools that they have at their home. I've seen it all. So it's not just I'm coming to your home. It's allowing me to understand what environment you're living in. It helps me with the treatment program too. It creates a more realistic situation. I know a lot of us are struggling and they're having hard times. And like I just talked to someone, he's like, I've been off work. I don't have the financial means to do what you want me to do right now. Give me an alternative until I can. And we did. I understood it. It's not uncommon right now. So it challenges us to say, okay, life's not perfect, but I'm going to figure out something for you to do in the meantime. So the new norm is what we're going to deal with. I'm not going to comment from a political, social, all that stuff, because Nicole won't let me talk for another 20 minutes. But to be honest, but I do want everybody to take a deep breath and understand that you judge people by their soul. And that's it. So peace out.